Good morning, Carmen. How are you?
Hello.
Hi, thank you for joining the HCM 345 live session today. My name is Katina Flagg, and I am the instructor. I will briefly turn on my camera. Good morning. Thank you for joining. As you know, these sessions are designed, for you guys to jump in, ask questions, um, to give you support in the course. Uh, I know the we host two of them a term, and so before, because I know they're like 30-minute sessions, we have like 15 minutes left before I jump into a lecture. Um, do you have any questions that are like homework questions, assignment questions, anything you need assistance with, so we can maximize the time and meet your needs as well?
No, I'm okay. I'm just gonna listen.
Okay, well, thank you for joining. As you know, this is your healthcare finance course, and this week we are studying chapter 3, which is Introduction to Claims Processing. Are you currently in healthcare?
No, I'm not.
Okay, so you're transitioning from another industry into the healthcare role, correct?
Yes, ma'am.
Okay, what brings you to healthcare?
I was just exploring my options as far as finance go, and it appealed to me.
Okay. Well, I started at very young age, at like 14 years old. So I had a pleasure of learning various aspects. So today we'll jump into the introduction of the claims processing. Through your readings, you should understand that like the claims processing is a part of the revenue cycle, and or either sometimes called patient financial services in some organizations, PFS. And this
Okay.
is where what things that you will learn this week in your studies pertain to the reimbursement methodologies. And as you know, the reimbursement methodologies are initiated by the Centers for Medicare and Medicaid Services. And a lot of most organizations are all filing their claims through the electronic platform using your CMS 1500s for outpatient services and your UB04 for inpatient services. These are just some objectives for this chapter, but just highlighting some of that in content.
Okay.
Okay. And so the a fee for service payment methodology versus a prospective payment model. These are some of the things that when you go through your readings for your chapter readings that you pay close attention to, as these are the learning objectives for this week. You also want to understand how to describe the financial relationships that are in violation of physician self-referrals and anti-kickbacks. So when you look at these class objectives, these are things that you should make sure that you have an understanding when you complete your reading and your work for the week. Does that make sense?
Yes, ma'am.
You should define and understand the uses of your advanced beneficiary notices. That's normally known as an ABN, and you will find reading to support that in the chapter as well. Understand and describe the appeals process in the healthcare reimbursement arena. So these are things that during this week you're reading that you should master and grab an understanding of. Any questions about those objectives before we jump in?
No, everything's
Okay. So, a little bit on the history, the types of payment. You had a retrospective payment um, party. Right now, you'll see that most organizations are on electronic health records, and they have electronics claims processing, and they also have third party administrators to help administer the claims going out the door and being paid on a timely basis. So when you look at the retrospective payment, the responsible party, right? So it tells us before the creation of Medicare and Medicaid in the 1960s, providers billed the patients directly. So they didn't have that third party liaison there, right? Because it was the provider and the patient. Generally was all cash pay back then. Once the prepaid health insurance plans, which are commercial insurances, most of us get that through our employers, were implemented, the providers continue to bill for all service provided to the patient. So no matter what they did, they charged them. And at that time, it wasn't a structured fee. You know, the providers charged based on their service and what they wanted to charge. Now there's more. The Centers for Medicare and Medicaid Services put reimbursement methodologies to make sure that it's fair across the board. So for different procedures, there's a standard fee, a rate that can be charged, based on geographical location. So if you came in Texas and you had a cardiovascular echocardiogram, it may be $10. But if you go to California, that same exam may be $17. And for example, the only reason that the fee structure is different is because of the cost of living. So there's some standardized structure versus, oh, this doctor in Texas want to charge $17 and then another doctor across the way charge $50 for the exact same thing. That's where the Centers for Medicare and Medicaid Services, they come in and they put some perspective around those billing and those fee for services. Does that make sense? Hello?
Yes, I'm listening.
Okay, great. So when we look at the prospective payments, today we are currently in a prospective model. This model allows for third-party payers to know what is going to be billed in advance, realize the cost savings, and promote cost-sharing types of organizations, such as managed care, Medicare, and Medicaid. One of the big impacts, as you know, if you're paying attention to the current administration, hospitals that are like public hospitals or heavily governmentally funded facilities are being heavily impacted by those Medicaid payments. If organizations have a large patient population of Medicaid, they're being significantly impacted because of the DEI initiative and the DOGE. So because of DOGE, that's the Department of Government Efficiency, they're looking at ways to restructure revenue. The patients and the services that are being administered to those Medicaid patients, which are the financially needy patients, has been restructured. Organizations that service that patient population are taking a huge hit financially, as up to some organizations $80 million since January, some organizations hundreds of millions of dollars since the new administration have gone into office. So there's a huge financial deficit in these organizations that's already forcing some facilities to start layoffs or looking at restructuring how they're running that organization, while at the same time they still have to service those patients and give those patients the adequate health care. So they cannot stop accepting Medicaid patients because they're not getting reimbursed for those services. Does that make sense?
Yes, ma'am.
You have any questions about that?
No, I'm okay.
Okay. So these are the various things that administrators and hospitals are looking at, those whole reimbursement methodologies. As you learn more about healthcare, you will see that there's robust systems in place, right? So, like, where are these patients coming from? Who's providing these services? So when you start looking at the providers, the suppliers, and the claims, so let's look at the providers. These are the type of people that are impacted, that are rendering services. So you have your hospitals, you have your critical access hospitals, you have your skilled nursing facilities, you have your outpatient rehab facilities, you have home health agencies, hospice, and clinics. These are service providers. Oftentimes you think of a service provider as being just a doctor, like the cardiologist, your primary care physician. But outside of the physical physicians, you do have other components of providers. Does that make sense as well? Okay. If you did not look at these entities as types of providers, now hopefully that's enlightened you to see them through a different lens. Okay. So these are your healthcare provider types. We just went through that. You have your acute care hospitals, your critical access, your SNF, the inpatient rehab, outpatient rehab, home health, hospice, home infusion, and DME, durable medical equipment. So when you see acronyms in healthcare, if you don't know what they mean, always take time to look them up. Remember, acronyms like the CAH, the Critical Access Hospital, that's an acronym. Acronyms should always be capitalized. Abbreviations are can be written in lowercase. So understand the difference between an acronym and an abbreviation. DME, durable medical equipment, that's another acronym. It should always be capitalized, should not be written in lowercase. When we look at suppliers, right? The types of suppliers that are in the healthcare industry are the physicians or other practitioners like nurse practitioners, CRNAs, your anesthesiologists, those sorts of practitioners as well, or an entity that furnishes healthcare services under Medicare, right? So Medicare is for our elderly patients, whereas Medicaid is for our financially needy patients. Sometimes you can have those patients that are Medi patients, meaning they meet the criteria for Medicare and Medicaid, and those are identified as Medi patients, right? In California, the Medicare patients are identified as Medi-Cal, okay, because they have Medicare in California and they identify their program as Medi-Cal. So you'll learn those entities and those various components as well. Every individual must meet the criteria in that program integrity manual. So to become a Medi patient, there's criteria that an individual must meet to meet that criteria. Medi-Cal, they have different rules, they have different guidelines, but you cannot, stakeholders can't just get a program and say that they want to be there. They have to meet that criteria, right? So all of those things must be, all of the criteria must be met. The billing is done separately when it comes to Medicare and Medi-Cal, and if they meet the criteria to be a Medi patient. Does that make sense? When you look at your claims, you have your CMS 1500 form and you have your UB04 form. You may hear people speak to the CMS 1500 form more frequently than the UB04 form. Let's take a look at these forms, right? The institutional, which is the hospital inpatient claim form, is the UB04. Okay. And so, excuse me. Sorry about that. Okay. My apologies. The UB04 form is your inpatient claim form. This form is this is the CMS 1500. Hold on. I saw that. Okay. So this is the actual UB04, the inpatient claim form. Like when a patient is admitted in the hospital, when the claims are submitted, they go out electronically. But all of the information on this form is actually filled in. This is an itemized form. So for instance, if the patient is in the ICU and they stayed in the ICU 10 days, you're gonna see a line item for the ICU bed charge for 10 days, $125 a day. I'm just throwing out a hypothetical number at 10 days, and it'll give you a total. If the patient had 32 pills that were administered. Each of those pills will be itemized on this statement and broken out accordingly. This is your UB04 form. That's your inpatient claim form. The outpatient claim form is your CMS 1500 form. This is for lab services, any type of outpatient treatment. And the misconception is that if a patient goes to the hospital and have a service rendered, that it's an inpatient form. That's not the truth. When I first started in healthcare, I did not understand that. I'm like, well, if they're coming to the hospital, why are we filling out this CMS 1500 form? Because this is a hospital, but they were never admitted. So you do have outpatient services like radiology charges, lab charges, those sorts of things that a patient may physically go to the hospital to have those services rendered, but they're not admitted. They're not under observation. They were just brought to the facility to have those services rendered, and then they leave, right? So that's when you use this CMS 1500 form, as well as when you go to your doctor's office for routine office visits. That data element is captured on this CMS 1500 form. Any questions about that?
So, I have one question. Is it ever an instance where the outpatient forms costs are more than the inpatient form?
You mean the services rendered?
Yes, ma'am.
It depends on how sick the patient is. I mean, there could be, let's say, a patient that was admitted for a 1-day stay and they were admitted for observation, which is a 24-hour observation. They didn't have any critical tests. They were just being analyzed, versus there could be some treatment that was done in a doctor's office on an outpatient basis that they're billing on the CMS 1500 form. Like a doctor can perform a procedure in his office. So it's a possibility that the fees could be higher, but that's on a case by case scenario. If the doctor does something in his office suite, it's possible. Not as likely, but it's possible.
Okay.
Yeah. Why, have you experienced where you had an astronomical outpatient visit on the CMS 1500 form?
My mother, she recently was challenged with some things concerning that form, and I was just thinking of things that she can maybe raise as concerns.
Well, as you know, if she gets her explanation of benefits that spells out from her insurance company what she's responsible for versus what the insurance company is going to be responsible for.
Okay.
So that's her first foundation. And if the services were rendered, she could go back and walk that claim form. She can also reach out to her insurance company to make sure what was submitted versus what services were actually rendered to her. So she can be an advocate, and you can help her be an advocate to walk through that. You guys do have that right, but understand exactly what was happening to her versus what her out-of-pocket expense and versus what her insurance company will pay. So just because she had the service rendered doesn't mean that her insurance company actually covers that charge. And that's sometimes the misconception. So you may want to check on that as well to see if that could be where the barriers are and why her out of pocket is now more than what you guys expected.
Okay.
Okay. Great question. Okay. So when you look, on these forms, you do have your revenue codes, you have your descriptions of the procedures, and you have your HCPCS codes, right? These are the services provided. The forms also carries the payer information, that's the insurance carrier, their health plan ID numbers, and the insurance name, which in this example would be your mom. Okay. Their diagnosis code, if they were admitted, they're going to have their admitted diagnosis, the reason for the admission, their principal and procedure diagnosis, and other procedure codes that are there. You're going to have your provider's NPI number. This is how the providers are identified. It's a national provider identification number. They can go globally. That number does not change. Okay. So this number is tied to the physician. That's part of how they get reimbursed. And it has to be completed on the form correctly along with their addresses. When we look at the CMS 1500 form, we're looking at the types of insurance they have. If they're Medicare, Medicaid, TRICARE, CHAMPA, whatever type of insurance they have, that's what we're going to select. If it's workers' compensation, those sorts of things. Okay. The form contains the patient's demographics, and all of this information must be correct. The name on the patient's insurance card must be the same name that's on their plan. So if I get married and my married name is Katina Jones, but my insurance says Katina Flagg, my claim could be denied because those names don't match. They don't have a Katina Jones in the system if that's what that CMS 1500 form is representing. So we need to make sure that the insurance and the hospital records match. Does that make sense? When you're submitting these claim forms, okay?
Yes.
All right. Any questions, comments, or concerns? No? So just make sure that all of the information, if it's a workers' comp, those dates are correct, the diagnosis, authorization, that all of the information on these claim forms are correct, that they're clean claims. When they go out the door, the claims must be clean. When you work in an organization, your organization is going to give you the basic foundation of your rules, the policies and procedures that you should follow to make sure that when these claims go out the door, that they're clean. Because if we do not send clean claims out the door, well, guess what? We don't get paid. So you need to know like what these services are being rendered. Like that's the place of service code. If it's at a doctor's office, if it's at an ambulatory treatment facility, understanding that basic foundation so that the providers are paid adequately, correctly. Does that make sense?
Yes.
Okay. So these claims and these funding entities, as you all know, you could see right now, patients or hospitals and organizations that have a large population of Medicare patients are being hit financially with the new DOGE diversity, equity, and inclusion situation that we have going on. And a lot of organizations are losing funds because they're not in alignment with that Medicaid guideline of releasing the DEI. So you will see some organizations having a huge financial impact. Some are being forced to close their doors. Some are being forced to lay off. So you will see, just pay attention to what's going on in the industry at this time. Okay, so these are the two claim forms that I introduced to you today to help you understand how organizations get paid. All of the treatment and services that are rendered inside the organization, they actually go out the door on those one or the two claim forms. If it's an inpatient claim form, they use the UB04. If it's an outpatient or ambulatory claim form, they use the CMS 1500 form. So that was a basic introduction of today's topics. Do you have any questions about that?
No, I'm good. Thank you.
Did you find this information helpful?
Very much so.
Awesome. We host two of these a session. So the other one I think will be in a couple weeks. I think it's the 27th or something like that. But there's a link for you to do a course review. I put that in the chat box at your leisure. Sound like you join from your phone. If you can click that link and finish that little survey, my boss would love to hear your feedback. And these sessions will be posted on our YouTube channel. And you can look at prior sessions as well. But I want to say thank you for joining this session. I appreciate you jumping on. And you can reach out to myself or any of your instructors for support. Please remember when you submitting your papers and your discussion posts to use that APA formatting. If you're not really clear on how to do that, please, get in touch with our librarian, make an appointment so they can walk you through those steps as well. And when you are doing your final papers and your research papers, include data and graphs to make your paper strong at the collegiate level. Okay? All right. Thank you for joining. No, thank you, and have a great day.
You too.
All right. Thanks. Bye-bye.